All right, there we are. Great. Just before we get underway, I want to ask if anybody has a case that they would like to present. And while we're at it, I have a very special guest. I pulled in one of my chief residents here to help with discussing a case today. So Nasir, are you able to unmute and introduce yourself and just tell us a little bit about yourself? What do you like to do in your spare time other than teaching medicine and running morning report and noon conferences and so on?
Thank you, Ravi, for having me. It's a pleasure and honor to be here. My name is Nasser Alhamdan. I'm a PGY4 chief resident here at Sinai Hospital. I was born in Iraq, grew up in the Middle East, and then moved to Canada around 12 years ago. I did my undergrad in Ryerson University in Toronto. And then I did my medical school in the Caribbean in a school called Medical Universities of the Americas. When I was in medical school, I happened to rotate as a student here at Sinai, and I loved it here. Loved the teaching. I loved the environment, the attendings here, the residents. So I wanted to be part of it, and here I am in my 4th year here at Sinai. Outside of medicine, well, I love teaching, I should say that, and I use every opportunity to teach. But outside of medicine, I love soccer, watch soccer, and play soccer, and football in the rest of the world, is what it's called. And if you're wondering what my favorite team is, Yasmin is asking, it's FC Bayern Munich. Very proud to say that because these days we're winning.
Oh, great to hear about your background there, Nasir. Lots of interesting things. I'm also a soccer fan, so Nasir played with me on our football team here at Sinai. So we've shared many battle stories and scars during various tournaments. So always fun to watch and also play. So we'll see if anybody has a case. If not, we'll keep waiting. Oh, Yasmin, yep, you have a case. We can be ready to go. You can start anytime you like.
Okay, if no one has a case, I can start presenting.
Yes, please.
Okay, so it's a 60-year-old male, presents to the emergency department with worsening shortness of breath over the past 24 hours.
Very interesting. Nasir, what do you think? Take a quick stab at that. Tell us what you think.
Yeah, it's a patient who is 60 years old coming here with shortness of breath, 24 hours. That is acute onset. There is, when I think about shortness of breath, I think about mainly the heart and the lung. This shortness of breath, especially with acute onset, I want to know more about it. Is it associated with chest pain? Is it associated with activity? Is it associated with wheezing? That will kind of guide me which pathway I want to take, because right now, it's still broad, but with a little bit more information, we're able to narrow down whether this is more cardiac related versus pulm related versus other system, but mainly the heart and lungs is what I want to focus on when I see acute shortness of breath.
Yeah, absolutely. I like that you framed it as acute. So we have a very vast landscape with shortness of breath here, but what could you sort of nitpick? I'm eagerly awaiting the past medical history, as people have mentioned, COPD exacerbation, for example. So if there's a history, COPD, maybe there's a flare, asthma, maybe there's an exacerbation, congestive heart failure, acute pulmonary edema. These can manifest very aggressively and immediately. So this can manifest in this time frame. So there are various frameworks that we can deploy here. We have the dyspnea pyramid, we have maybe we can follow the pathophysiology with VQ mismatch and dead space ventilation and so on, high altitude, low FiO2 and so on. But here it's pretty early, so I really don't know. But a couple of things sort of sprung into mind, like pneumothorax, that can be just sudden. ACS could actually manifest very suddenly as well. So maybe doing some activity. So again, the landscape could involve both cardiac and pulmonary. Other things could be progressive. So like a pleural effusion, we had a case of that the other day. That is kind of slow, progressive, would occur over a subacute to chronic sort of time frame. Less likely here, but those are a few thoughts. So we'll go on with the next aliquot.
Okay, so the patient reports associated cough without a sputum production with similar onset. In addition, he reports generalized malaise and myalgias for 2 weeks. The patient has not taken his temperature at home, but he reports feeling febrile. He has not noticed any particular pattern with this fever, starting that they have waxed and waned over the past 4 to 5 days. He states that malaise has been progressively worsening over the past week. He denies any known sick contacts, and that's the next aliquot.
Oh, interesting. A bit more data here. What do you think, Nasir? How can we expand our thoughts here with this data?
Yeah, so we went from being very broad and not knowing which pathway to take, but now with this information, I am able to kind of lean towards infection etiology more than anything else, mainly because he initially started with malaise and myalgia for 2 weeks. Then he started to develop more worrisome symptoms, the cough and the sputum without sputum, but the cough is now, and now he's having dyspnea. So putting that together, it could have been a viral illness that he was dealing with, now has probably progressed to affect the lung, and perhaps a post-viral pneumonia that we should think about, especially that he's feeling febrile. Though, you know, we cannot confirm that until, of course, we get imaging and probably know a little bit about the physical exam.
Yeah, I really do agree with a lot of you mentioned there. So I'm just going to nitpick and just say, take the cough component of this. Yeah, the dyspnea is glaring. I want to know what the pulse ox is, but association of cough, like you mentioned, you know, when we look at acute cough, usually it's less than 3 weeks duration. You start thinking about, you know, cough could be due to upper respiratory tract infection, so viral etiology. There could also be other things like allergic rhinosinusitis, pneumonia. If there's a febrile component, patient has myalgias, malaise, so something is dragging the patient down. Could it be an infection? Could there also be some other component like anemia? So we didn't go into the hematological areas, but that definitely is something I'm thinking about too. So anemia can make you malaised, fatigued, can also give you dyspnea without severe hypoxemia. What else could cause this? A cough you could have with pulmonary edema, that could be acute too. So if you have like associated fever, if you have associated chest pain, if you have associated like this patient dyspnea, you have to start thinking about serious conditions like we mentioned, pulmonary edema, pneumonia, any sort of cardiovascular disease that can, or that is something that we have to think about in the initial process. So any other thoughts, Nasir, before we go on to the next aliquot?
Yeah, I think you're in the right track, Ravi. But also something I also want to mention, I'm eager to know about the past medical history. Is this patient's immunocompromised, immunocompetent? That kind of also opens another window. If the patient is immunocompromised, then I would also think about opportunistic infections in this case. But I'm eager to know more.
I just love that thought. I didn't really weigh into that too much, but you're right. That opens the door on a numerous amount of medication. I mean, infectious diseases, like you mentioned. So, does this patient have HIV, for instance? So, PCP comes into play. Other viruses could also come into play. You may have for a non-immunocompromised patient or a normal patient, you may have viruses like adenovirus, rhinovirus, RSV, and so on. Immunocompromised, you may end up having like CMV, varicella, herpes virus, things like that, in addition to PCP. Also, you could bring in fungal causes of pneumonia as well. But we need to get more background on this patient before we do a deep dive into maybe cough and fever and shortness of breath in an immunocompromised patient. Back to you, Yasmin.
Okay, now for his past medical history, he has diabetes mellitus, non-insulin dependent, Hashimoto thyroiditis, hypersensitivity lung disease, and GERD. He takes metformin, levothyroxine, he lives alone, he has no pets, he denies any recent traveling or hiking, and denies any current sexual partners. Should I go on?
Yeah, I think we can go on till the exam, do the exam as well.
I have the temperature. I'm sorry, I don't have it in Fahrenheit, but in Celsius is 38.8, which is fever already. Heart rate 114, blood pressure 90/50, duration of 94% on BiPAP. I don't know if that's pronounced correctly. With BiPAP, it's 100%, and respiratory rate of 24. Now, in general, the patient is diaphoretic. He is an ill-appearing male in moderate to severe distress. He has no conjunctiva icterus. The neck is supple. There's no cervical lymphadenopathy noted. There's moderate respiratory distress. There are rhonchi noted through all the basal base of the lungs. The patient was unable to speak in full sentences. He's tachycardic with regular rhythm, no murmurs, no rubs or gallops noted. The abdomen has splenomegaly. The abdomen is soft, non-tender, no rebounding or guarding, normal active bowel sounds. The extremity, there is no edema, no cyanosis. He's alert, oriented to time, person, and place. There are no supraclavicular or axillary adenopathy noted. And the skin is diaphoretic, warm, and no rashes.
Extremely well presented there, Yasmin. So a lot of information there. What do you think, Nasir? How would you now integrate the physical exam into your thought process and come up with a hypothesis?
Yeah, the first thing that I noticed, of course, with the vital signs, when you see patients who are tachycardic, febrile with an elevated temperature of 38.8, that's kind of high, and also tachypnic, those combinations kind of shouts at you sepsis. And I would, especially when it comes to seeing a patient who are diaphoretic, ill-appearing, in the severe distress, I would have a very low threshold to call the ICU on this patient, because this patient have high risk of decompensating, and he's already on BiPAP. Now, when it comes to the physical exam, finding rhonchi on the lung bases tells me that it's a non-specific kind of physical exam finding, but we do see it in mainly pneumonia, and we can also see it in other diagnoses such as ILD. But in this case, given the patient's temperature and the presenting symptoms, pneumonia would be on top of my options. The other thing that caught my eyes is hypersensitivity pneumonitis. We don't usually see this past medical history in a patient. It just caught my eyes, and I was just thinking out loud, is that, is the patient is still exposed to what's triggering this hypersensitivity pneumonitis. Remember that hypersensitivity pneumonitis is a lung response to any chemicals, any animal proteins, anything in the environment that can trigger all this. With this time frame, I doubt it, but it's always good to keep it in the back of our mind when we see the images of this patient. But you know, Ravi, I think pneumonia is what we're dealing with here, probably. What do you think?
Yeah, I agree there. I'm very concerned about this patient. There is a pattern of hemodynamic instability here. The oxygen patient is requiring a high amount of oxygen to maintain 94%. So if you were to calculate their PO2 over FiO2, it would not be in the usual 600 and so on. That would equate with normal oxygenation. So they're requiring an abundance of oxygenation to maintain appropriate PaO2. So this patient, I'm concerned, like you mentioned, on the exam, the bibasilar rhonchi, so bilateral process. I was anticipating a nice sort of a lobar process that would indicate bacterial pneumonia. Most common causes being strep pneumo and so on, atypicals, H flu, also Legionella could have come into play. Fungal pneumonias, if the patient is immunocompromised. Patient has diabetes, so is immunocompromised somewhat. So less likely fungal, cryptococcus, PJP, and so on. TB, I don't think would manifest as acutely as this, and there would be associated features, maybe some hemoptysis, but you could get hemoptysis with a bacterial pneumonia. Now, it's interesting that the chat has brought up maybe allergic causes, hypersensitive pneumonitis you mentioned. I would look for somebody like with this patient plus sepsis. I would immediately weigh in on the side of bacterial infection. Viruses, possibly not, unless they're superimposed bacterial pneumonia. We're in the age of COVID, so definitely COVID has to also be considered in this patient. But a patient with AIP, UIP, COP can manifest with this. You can have fever, cough, you can have malaise, but months of it, I think. And that usual presentation is a patient that's been on antibiotics, has been treated with non-resolution. So that patient is treatment refractory, and then you look further down to see what else is going on, and COP comes into play. So I'm still sort of on the fence about what's going on, but we would do, like you had mentioned, we need imaging, we need an ABG, definitely, the patients on a BiPAP. We also have to make sure while we're treating the patient on BiPAP, they don't have contraindications to BiPAP. So this patient would have to urgently be escalated to mechanical ventilation and intubation, and do all the usual workups, the urine, Legionella antigen, strep pneumo antigen, blood cultures. So in the workup of a patient that's this sick, that's going to maybe an intermediate care, ICU, the guidelines would suggest to do all testing. If a patient goes to the floor, you may not need to do all of this testing. So the patient's relatively stable, but for this patient is unstable. So we would have to do all the workup, including blood cultures. And a patient going to a higher level of care, we would have to cover for MRSA, Pseudomonas, irregardless if this patient has been hospitalized within the last 90 days, been on IV antibiotics within the last 90 days, which would put him in a former category of HCAP, but is now known as CAP with MDR features. But going to IMC, ICU, you would definitely have to cover for those, plus atypicals. So we'll see what the laboratory data shows before we further focus on what could be causing this. Back to you, Yasmin.
Okay, now for the CPC, the patient had an hemoglobin of 9.2, white blood cells of 2.5, and platelets 87. Absolute neutrophils of 890 cells per microliter. Peripheral smear, should I give?
Yasmin, we didn't hear you.
Oh, should I give the peripheral smear?
Oh, sure, go ahead.
Okay, Rare atypical lymphocytes, no dysplasia, blasts, or schistocytes. For the chemistry, sodium of 127, potassium 5.2, chloride of 89, CO2 29, BUN 43, creatinine of 2.18. The baseline is 0.9. Glucose is 106, AST of 735, ALT 117, bilirubin of 9 points, direct bilirubin 8 milligrams per deciliter. Should I give the PCRs and cultures?
Yeah, I think we can do that. Yeah.
Okay. So for the COVID PCR was negative. There was no growth in blood cultures. Infectious and autoimmune workup was negative, including EBV, HIV, and influenza. Should I give you the image or we wait?
I think we could stop here because this
Okay.
is very interesting data. And I'll let Nasser take a stab at it and, before I weigh in.
Yeah, the lab findings have a lot of significant findings. The first thing, of course, we should mention is the white count. It is pretty low. Remember, and a lot of us forget that when we think about sepsis, that it's not only the white count could be elevated, but also sepsis criteria also have a white cell count below 4,000. That we should always keep in the back of our minds. So when I see this in the sepsis picture, that should always trigger in my mind that it could be from sepsis. But other etiologies with low white counts, I'm thinking about with the hyponatremia as well. When it comes to pneumonia, I'm thinking about Legionella. That could also be precipitant, but with Legionella, you would also see sometimes patients have diarrhea, some other symptoms along with that. So I wonder if urine Legionella was also obtained as part of the workup. Atypical lymphocytes is another thing that's also I noticed, Ravi, an atypical lymphocyte. I see it's commonly in EBV. So I'm glad they were able to obtain that and roll that out. I can't recall of any other specific diagnosis that would have atypical lymphocytes, Ravi, but EBV is what came to mind, and we rolled that out.
Yeah, that really did stand out. So this patient does, like you mentioned, there's pancytopenia. So what is going on here? I think it's likely secondary to a process, but I'm definitely tracking it. Am I going to go into the differential of it if it's a peripheral process, a bone marrow process, destructive process? I don't know yet, but I definitely will keep it on the back burner. But yeah, jumping to this peripheral smear, our good friend Anne-Marie Comfort is on here. And remember, Anne-Marie, you did a EBV case, then a CMV case, and we learned tons from those cases. So viral phenomena, definitely that could indicate a viral etiology. But you know what atypical lymphocytosis could be, if you think about it, there are a number of other conditions that could occur. So, B-cell leukemias, namely could also be a manifestation of this. As far as the chemistry, it was interesting. Well, in the chat, people mentioning the hyponatremia. Could this be associated with Legionella? And then the AST, because the ALT is normal, AST could be a sign of destruction somewhere. So at first glance, is there hemolysis? So AST would be elevated in that case. Second glance, is there any injury, ischemic injury to liver, kidney, lung as well, or cardiac? It could be due to a cardiac etiology. Sorry, not lung. Lung would be LDH. So cardiac myocardial infarction could also trigger AST with release from ischemic damage. Then also comes leukemia, lymphoma, and vasculitis. So AST could be a signal of that. The bili indirect is 9, so the direct is 8. So the direct is pretty high. So that also could indicate there could be hemolysis going on. And if we look, there's no schistocytes. Okay, I thought I heard schistocytes, but there's no schistocytes. So there's no hemolysis that's actively going on. So where could this be happening? Yeah, I'd have to think about that, especially with the pancytopenia. So at this point, with all of this, somebody had mentioned, with all of these different lab abnormalities, could there be a process going on that there is sepsis, but then the sepsis has snowballed into a cytokine storm process? So cytokine storm syndrome associated with COVID, but many other, could be malignancies, can also have association with EBV viruses as well. CMV, I think, could also be associated with that. Other things, macrophage activating syndrome, and then HLH, the syndrome that I was blindsided by, I think, over a year ago, because there's just so many different parameters and criteria that I can't possibly remember all of those. But a ferritin could help, as it's one of the criteria, but it's not the criteria. But we'll see if Yasmin has that in store, as people in the chat have mentioned. Back to you, Yasmin.
Yeah, I do have it, and I have the imaging. So before I jump to the imaging, we have a CRP of 336.8, ESR of 26. Ferritin was higher, 40,000, like really high ferritin. LDH was higher than 43,000. Fibrinogen, 29.3. Now I can share my screen to show you the you let me know if you can see my screen.
Yes, we can.
Okay, so he had in the X-ray called patchy bivascular predominant airspace opacities, suspicious pneumonia. CT chest, abdomen, and pelvis with contrast demonstrated splenomegaly and was negative for pulmonary embolism. And they also had a liver ultrasound with duplex with a hepatic vasculature with normal directional flow. So I think Aya can start screen sharing. So I don't know if you looking at the X-rays.
Yeah, Nasir has a interest in pulmonary critical care, so this is right up your alley. Any comments on what you think this X-ray means to us, or means to the physicians that tackle this case?
Yeah, certainly. I am not looking at this X-ray. I'm not surprised that the patient is on BiPAP or in severe hypoxic respiratory distress. I can see that there's diffuse infiltrates on bilaterally, more presence on the bases, and when I see this, I always think about ARDS versus bilateral pneumonia as top of my mind, and its characteristics of that, and given the clinical picture, I would think about infectious cause with this diffuse infiltrates that has progressed, and could we be dealing with a new onset ARDS with this clinical picture? It's very possible.
Yeah, definitely. This picture, looking at it, it's a bilateral process, but with the severe amount of disease there, that the volume, lung volume that this disease process has taken up, I doubt it's looking very much like pulmonary edema. But like you'd mentioned, there's initially an insult on the lung, say an infection, any one of those infections that we talked about, and then with massive inflammation causing, like you had mentioned, ARDS. And ARDS, if you remember going through the criteria, it has to be of immediate onset, so usually within a week. And this happened acutely, so it could even happen within 24, 48 hours. You're going to have bilateral opacifications like this, but always remember, it looks like pulmonary edema, but it's non-cardiogenic in origin. So if you did float a Swan-Ganz catheter, the pulmonary capillary wedge pressure would be low in this case. So this would be a non-cardiogenic pulmonary edema. And then the severity of ARDS will be evaluated by the criteria, the PaO2 over FiO2. So this is known as the Berlin criteria. So you want at least less than 300 on this criteria, and I think severe is like less than 100, if I'm not mistaken. So going back to this other data with the CRP, it is extremely high. I am not used to seeing something that's this elevated. So CRP can correlate with interleukin-6, a few other inflammatory mediators. ESR, what's interesting, CRP is higher than the ESR. So I'm not sure why there's a discrepancy there, but moving on to the ferritin, as we had requested in the chat, was eagerly awaiting for, it is very high. Now, again, our friend here, Dr. Kumfer, did a great schema on ferritinemia, which I remember, and I have in my Glass Health notebook. She went through all I definitely would recommend everybody to look at it. So she went through the causes of hyperferritinemia. So things that come to mind, of course, hemochromatosis, histoplasmosis, HLH, namely, also comes to mind, adult onset Still's disease. But we don't have a panel of rheumatological illness, autoimmune phenomena here. So I guess with this patient, yes, COVID could definitely cause HLH. COVID is negative. Does it necessarily mean a negative test discounts COVID? It could still be at play. But yeah, I'm very much on board the HLH train. And any other thoughts, Nasir? I'm kind of...
Yeah, I mean, the CRP, the ferritin level, these numbers are strikingly high, and definitely shouting malignancy versus HLH, like what you're mentioning. Could this be just in the background of something that has been undiagnosed for a while, and on top of that, the patient has developed pneumonia, and that what brought him to the hospital? Who knows? I'm eager to know more.
Yeah, and yeah, it's a very difficult diagnosis to make. The criteria is quite broad, but yeah, the splenomegaly here, looking at the hematological phenomena, there is a background of infection, which could be a trigger for this. So that definitely is high in my hypothesis generation here. Yasmin, any other data before we go in
yes,
on?
I have the bone marrow biopsy, which will actually give you the diagnosis.
Go ahead.
So in the bone marrow biopsy, there is a limited minimally hypercellular bone marrow, 50%, showing trilineage hematopoiesis, increased sustainable iron stores, and hemophagocytic histiocytes were identified.
Nasir, what do you think?
I think that, like what we thinking about, having a bone marrow disease or a malignancy in the background, kind of HLH kind of, was high on our differential looking at these lab values. And with this bone marrow biopsy, I would, get oncology on board to take a look at it and guide us through treatment further.
Yeah, definitely. The bone marrow biopsy definitely helps here, and like Anne-Reed mentioned, it's not what we're trying to. I guess in other words, we're trying to figure out what is the cause of this. So this whole hyperinflammatory cascade is going awry, and we have to get to the bottom of what exactly is causing this. So again, there were a number of different thoughts. Definitely pneumonia is there, ARDS is there, and now this patient is in HLH, and like you mentioned, definitely will need expert help in trying to address this. Going through like the abnormalities, we have cytopenias here, we have the elevated serum ferritin, we have liver function abnormalities, do we have coagulation abnormalities, and we have systemic issues. Is the background, I think we are all agreed on there's an infectious process in the background. Malignancy can also be at play, rheumatological issues could be at play, some things to think about, but I'm pretty much on board the infection train at this moment. Any other thoughts, Nasir, before we get the final diagnosis?
Yeah, I think infection is the highest on our list. I agree with you, Ravi, and there is a background malignancy, bone marrow disease going on, and I think that's what we're suspecting. But let's hear the answer, I guess.
Yeah, just before we do that, yeah, going back to, remember I paused at the pancytopenia. So that when you're dealing with so much data here, you have to logically in an analytical manner go through the data and see what are you going to concentrate on to narrow down the diagnosis, or what are you going to track and put on the back burner to consider later. So definitely there is bone marrow involvement, but as we go along, it's making clearer sense, like you mentioned, bone marrow involvement, and the answer lied in the bone marrow getting that biopsy. So one of the causes of bone marrow failure when you have pancytopenia, if you look at that schema, is HLH. So back to you, Yasmin.
Yeah, so the final diagnosis was HLH. The patient was started on high dose of steroids along with chemotherapy, which resulted in rapid improvement of both subjective symptoms along with history symptoms, and was able to be discharged from the hospital on room air with close hematology follow-up, although it is true that the main causes or triggers of HLH are EBV, other viruses such as varicella zoster, measles, CMV, parvovirus, even COVID-19. There was no case, cause identified in this patient. Wow,
incredible. This is the second case of HLH. The last time it was Franco, who's it's his birthday today, actually, and he's in ICU, quite busy, and he couldn't join us. But interesting that we have another case of HLH, and he stumped me the last time with an HLH case when I was discussing with Reza on a Friday VMR. So I think space learning is key here. So definitely the takeaway message is, HLH is rare, but you do need to know the whole criteria for that before you jump on the bandwagon of HLH. Nasir, any final thoughts?
Yeah, it's amazing how we reached to HLH as a diagnosis. Now, actually, it'll be interesting to also go back and see, looking at the criteria and see which one would fit in our patient. And now all the lab findings actually make sense, because a lot of is explained by the HLH, the splenomegaly, the low white count, the low platelets, the ferritin, the LDH, all now fits into the picture of HLH. So great case.
Yeah, thank you, Yasmin. Great case, and really well presented. I want to applaud you for a great presentation. Mukund, teaching points?
Yeah, let's do it. This is another HLH case for me and stumped me as well. So this is good space learning for me. Thanks, Yasmin, for presenting the case. We'll just go through some of these teaching points. We started off by talking about dyspnea as a chief concern, and with little other information to go off of, we primarily focused on cardio versus pulmonary etiologies, with a really great point that anemia can also cause malaise, fatigue, and dyspnea, so should add that to the differential. we did pretty rapidly get some more information about fever and malaise, and so we started considering infection. And in this patient, after getting some of the physical exam findings, the vitals, we were worried about sepsis in a patient already on quite a bit of oxygen. Continuing onwards, our finding of bronchi we thought was associated with pneumonia as a primary presentation, and we went through a brief differential for some causes of pneumonia, including strep pneumo, H. flu, Legionella, and then in people who are immunocompromised, pneumocystis jirovecii and Cryptococcus. Our blood smear had some atypical lymphocytes, which we played around with the idea of these being Downy type 2 cells, which are classically associated with EBV, but that was ruled out in the lab section. We had a great discussion about causes of isolated AST elevation with normal ALT, and we considered ischemia, for example, MI, leukemia, lymphoma, some vasculitis, and causes of hemolysis. In the chest X-ray section, we had a great discussion of criteria for ARDS, which requires an immediate onset within a week or so, and in this case, it was a day. Bilateral opacifications and pulmonary edema not of a cardiogenic cause, so with a normal pulmonary capillary wedge pressure. And we talked about the severity of ARDS being evaluated by the Berlin criteria, among which includes a calculation of PaO2 over FiO2, with mild being less than 300, so on and so forth. And finally, we went into this discussion of causes of hyperferritinemia, among which our final diagnosis, hemophagocytic lymphohistiocytosis, was involved. So I have a little bit here from the last time we learned about HLH, about what it is, just a family of hyperinflammatory states that can be caused by an inappropriate hyperactivation of immune cells. And in the past, we've talked about this either being primary, for example, as a cause of mutation in perforin enzymes, or being associated with other genetic diseases such as celiac Higashi. And in this case, we talked about it being secondary, most likely following an infection, although a cause could not ultimately be identified. And for your learning, I've put in the H criteria as well. There are 8 of these that are required to make this classification of diagnosis. You need 5. We definitely had at least 5.
Awesome job, Mukund. Great to see you back here. We definitely missed you, and your teaching points are fabulous. So I didn't know about celiac Higashi also causing that. So thanks for putting all those extra teaching points in. Thank you, everybody. Have a great afternoon. Thanks for joining us, and look forward to seeing you here tomorrow. Take care. Bye.
Thank you, everyone.